Hello everybody. I'm happy to welcome you to today's session with the Sickle Cell Awareness Group of Ontario. We're going to start, as always, with a land acknowledgement. Now, the statement that I'm going to make is specific to the area now known as Toronto, but this is an opportunity for all of us to acknowledge the First Peoples on whose traditional territories we live and work. For thousands of years, this land has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to work on this land. So welcome again. I'm Dr. Jennifer Bryan from the University Health Network in Toronto, and I'll be your moderator for today's session. A few housekeeping items before we begin. So first, hopefully you've seen the message when you first started the session, that the session today is being recorded and will be available on the SCAGO website at a later date. In the first hour of today's session, we'll have presentations from our expert speakers who I'll be introducing shortly. In the remainder of this session, there will be time for questions and discussion. Please do feel free to post your questions in the Q&A throughout the session, and we'll address them in the Q&A portion of the talk. After the session, there'll be a short poll for you to complete. It's very fast, it takes less than 2 minutes, and is very helpful for the organizers of these educational sessions to know what topics might be helpful in the future and what things about the session you'd like to see more of in the future. I'm honored today to introduce our speakers. First, I'd like to introduce Dr. Uma Atali. Dr. Atali is a professor in the Department of Pediatrics at McMaster University. She graduated with a Bachelor's of Medicine and Surgery degree from the University of Bombay in India. After her pediatric residency training and MD in pediatrics, she worked in Zambia in sub-Saharan Africa for 6 years, where she developed a keen interest in pediatric hematology and oncology. She was offered a postdoctoral fellowship at St. Jude's Children's Research Hospital, which is a pioneer institute in pediatric oncology. After completing her training in the USA, she joined McMaster University as an assistant professor in 2001. She's the director of the Pediatric Hemoglobinopathy Clinic at McMaster Children's Hospital and is actively involved with clinical support and education in pediatric hematology and oncology in sub-Saharan Africa. I'm very excited to be welcoming Dr. Atali here today.
Thank you, Dr. Bryan, and thank you, SCAGO, for inviting me.
Dr. Atali's co-presenter today is Dr. Suzanne Williams. Dr. Williams completed a BSc at McMaster University in Hamilton in 1993. She completed medical school at the University of Toronto in 1997. She completed her pediatric and pediatric hematology oncology training at McMaster in Hamilton, Ontario in 2003. She joined the full-time faculty in the Pediatric Hemostasis Program of the Hematology section in the Division of Hematology Oncology at the Hospital for Sick Children in 2003. Currently, she's a clinician specialist in the Department of Pediatrics and an associate professor at the University of Toronto. She completed a Master of Science in Health Research Methodology at McMaster University in Hamilton, Ontario in 2006, and a Master of Science in Hemoglobinopathy through the University College London in the UK in 2000.
Hi, good morning, everyone. My name is Ika Washington. I'm the communications manager for SCOGO, as well as the COVID-19 counselor. Dr. Brian just happened to lose internet, but this is the thing with technology and doing Zoom. So we'll just hang on. I cannot fill her shoes, I promise you that, but she will join us shortly as she logs in. In the interim, I don't know if Dr. Uma or Dr. Suzanne would like to continue their introductions or just give a little tad bit of what to expect for their presentations.
I can go ahead and speak. My intro was basically completed, and I'm going to be starting, so I can go ahead and start sharing my slides now, and we'll be happy. I hope you can see my slides.
Yes, we can see them. Thank you.
Perfect. Thank you. Okay, so we'll go ahead and get started. And I will be doing the first part and as discussed, and then we'll hand over to Dr. Thali in a few moments. So the agenda for the seminar today is to discuss what is a stroke, with a starting point of a case with a brief description of stroke, and then go on to the why, when, who, the pathophysiology, the risk factors, and diagnosis of stroke, and then return to myself to cover management of stroke and prevention of stroke. So we'll start with our case. So this is case AB, who is a 3-year-old girl who has hemoglobin SS, sickle cell disease, that was diagnosed on newborn screen after an uncomplicated pregnancy. She had normal development and growth, and at age 3 presents with a sudden onset of a left-sided limp, was noted to be dragging her left foot while she's walking with no history of preceding injury or trauma. She's taken to the emergency room by her mother and identified there to have a left-sided paralysis. She has brain imaging completed via the emergency room, and a CT scan of her brain shows she has had a stroke. So what is a stroke? So stroke is essentially a loss of blood supply to an area of the brain. And with that loss of blood supply, the brain tissue loses the oxygen and nutrients that would usually be supplied via the blood source. As a consequence of that, you'll have eventual death of the brain tissue. So there's not immediate death, but within a few minutes, the brain cells will start to die. There are different categories of stroke: overt versus silent. Overt meaning there's an obvious stroke happening based on clinical symptoms, and hemorrhagic versus ischemic stroke, which Dr. Thali will talk more about. So our traditional way of thinking of stroke, as demonstrated in the diagram there to the right, is that this is a slice of our brain sort of laid out, and the blood supply, as you can see there going to the brain tissue, is that within the blood vessel at some point, which is bringing the blood supply with the oxygen and nutrients, there is an occlusion or a clot or a clump of sickle cells that leads to a blockage and the subsequent loss of blood flow. So a stroke is a brain attack. So we talk about a heart attack being something that is an emergency and urgent, in very much the same way a stroke is a very emergent event. So think and act fast. This is some of the sort of stroke acronyms that are out there. Fast meaning looking for the symptoms. So is the face looking uneven? A sign of paralysis. Is the arm drifting down? Again, a sign of paralysis. Is the speech altered or sounding strange? And if any or all of those things are present, it's time to call 911. This is a diagram from our stroke or sickle cell education book. So anyone who's been through the sickle cell clinic at Sick Kids will recognize this picture. It's an old book now from 30 or 40 years ago, but I remember coming as a trainee to sickle cell clinic and seeing the nurse in clinic pulling out this huge book and going into chat with families about different aspects of sickle cell disease, but really demonstrating here again that this is a blood vessel cut open for you to be able to see the cells flowing within it. Here's the sickling process occurring with these cells going from their donut round shape to the sickle shaped, leading to blockage of the blood vessel and an absence of the ability for the blood cells to continue to flow through, leading to a downstream effect of loss of flow to that area, which can result in the signs and symptoms of stroke. So seizures, unsteady walk, slurred speech, weakness, vision loss or changes in vision, and paralysis. So a silent stroke, which Dr. Athali will talk more about, is where you don't have those overt or obvious signs and symptoms. So the brain tissue is still being damaged or dying, but you're not seeing anything on the outside of the individual that would demonstrate that this process is going on. And this is very common in sickle cell disease, 27% before age 6, 37% in up to age 14. So ischemic and hemorrhagic stroke I identified was another way of thinking about stroke. So I have 3 rows on the slide here. So an ischemic stroke is the first one here. What the blood vessel would look like is in the second row, and what the brain tissue would look like on imaging is in the third row. So the bottom images are CT scans, which is basically a radiation scan, and it takes the brain imaging in slices. So you see the slices represented here of the different aspects of the views of the brain. So when you have an ischemic stroke, there's an area of the brain tissue that's deprived of blood supply. And so that area is, again, a result of blood flow being obstructed by this clot, occlusion, sickled clump of cells where blood flow can no longer go through, and the tissue dies as a result of that. It looks like this on your CT scan, this wedge-shaped area of death of tissue or tissue loss. A hemorrhagic stroke is a little bit different. So instead of a blockage within the vessel preventing blood supply, instead you may have a rupture to the blood vessel where blood is leaking out of the blood vessel. So blood is no longer flowing through to its endpoint, not because there's a block, but because it's being leached out into the surrounding tissue rather than getting to its target destination. So you get an area of bleeding rather than a blood deprived area. So there's blood there, but it's not coming through the blood vessel to supply the oxygen and nutrients in the way that the brain needs. It will look like this on your CT scan. It's a little bit different in appearance, but again, sort of this area of tissue damage as a result of the event. So it's a brain. So what's a stroke? It's a brain attack. It's a medical emergency. It's damage and death of an area of brain. Okay, and at this point, I will actually hand over to Dr. Athali. So I'm going to stop sharing my slides. Just give me 1 sec.
Thank you, Dr. Williams. Just want to remind everybody who is listening to feel free to put any of your questions into the Q&A, and we will be having a Q&A session after the talks by Dr. Athali and Dr. Williams.
So thank you, Dr. Williams, and thank you, Dr. Brian. So continuing on the presentation, so the questions, so going back to the case that Dr. Williams started off with, the obvious questions that AB's parents are asking is that really a disbelief of stroke in this young child. Because when we talk about stroke, typically the stroke happens in the older individuals with a lot of other issues. So a 3 or 4-year-old girl presenting with stroke is quite unusual. So the questions obviously are, how common is it and why did she have it? So stroke is the leading cause of mortality and morbidity in patients with sickle cell disease. The risk of stroke in general pediatric population without any problems is less than 1%. So you can imagine how rare it is. However, a child with sickle cell disease has over 300 times higher risk of stroke. And the highest risk is during the first decade, especially during the 2 to 5 years of age. So AB kind of fit that criteria. There was a very nice study done by investigators in the USA, known as a cooperative sickle study of patients with sickle cell disease. This was an observational study of a big cohort of children born with sickle cell disease and followed through the life. So it's abbreviated as CSSCD study, which showed that about 11% of children and young adults with hemoglobin SS or sickle cell anemia will develop stroke by 18 years of age. And by 25% of will develop stroke by 45 years of age. Now, since this study was published, it started conducted in about 1998 and it's published soon thereafter, there have been a lot of progress made in the evaluation, prevention, and management of stroke. So the epidemiology as we see in 2020 or in few years in 2021 will be a little bit different. And I hope that the risk of a stroke is much less in patients with sickle cell disease who are managed in comprehensive care clinics across North America. However, majority of the children with sickle cell disease are born in Africa and countries like India, where the comprehensive care or primary stroke prevention or even a screening is not available. And these patients from these countries gives us a window or snapshot of what really is happening. So the graph on the right-hand side shows that it's a projection of what will happen by 18 years of age. So as you can see, if there are about 1,000 children with sickle cell anemia, about 500 of them would have some form of neurological event by the age of 18 years. About 110 would have frank stroke, and about 390, so about 39%, would have silent cerebral infarct. So stroke is a major problem in patients with sickle cell disease. The subtypes of strokes vary with age. Dr. Williams has nicely told us how an ischemic stroke develops and an hemorrhagic stroke develops, right? This graph, which is again done results from the CSSD study, shows that ischemic stroke is highest during the first 20 years. So there are two peaks, one before the 20 years of age, and then gradually it occurs in the fourth or fifth decade. And that kind of also results associated with other comorbidities that adults would have. The hemorrhagic stroke, as against, is most commonly seen between the age group of 20 and 30 years of age. And silent stroke would develop in about 10 to 30% of patients. And it is not age dependent, and we'll talk about it a little later. So the next question the parents would have is, how do I know that me or my child have a stroke? So again, common signs and symptoms. Dr. Williams briefly went over the signs and symptoms of stroke in general. But the clinical presentation varies with the size and location of the stroke that one has. It could be catastrophic if a large area of the brain suddenly undergoes blood deprivation, as with a big clot, or if there is a big bleed resulting from vessel rupture. Or it could be a transient. So for example, if there is an occlusion which is kind of occurring with vessel spasm to begin with, then you can have some transient symptoms like maybe weakness of face or arm or leg, which lasts for a short period of time and then disappears. But even if it is disappearing and the child or the patient looks normal, it's an important sign because it kind of gives you warning of the stroke. It's an important sign that one needs to seek medical attention. The stroke symptoms or signs will also depend on where is the stroke happening. Most of the stroke which happens in the anterior part of the brain would present with either motor deficits like weakness of arm or leg, speech defects like either inability to speak or slurred speech. There could be onset of seizures, and the seizures can happen either as staring spells, what we call focal seizures in the form of just twitching of arm or leg, or generalized seizures where the patient convulsing very violently and loses consciousness. If the stroke, as against happens on the posterior side of the brain, then it could lead to ataxia. It can cause severe headaches, vertigo, or vomiting. In young children, sometimes these symptoms are very difficult to differentiate from the common illnesses. Like if the patient had injury and the patient is dragging his or her leg, then one may think that, oh, this is just because of the fall. So just watching and making sure that it's not worsening or it's persistent is important. Sometimes the stroke symptoms may be absent, as it happens with silent cerebral infarcts, or the symptoms could be insidious, like cognitive dysfunctions or poor school performance, failing grades. These are all signs that there might be some neurologic damage happening because of sickle cell disease. The ischemic stroke, as we said, it happens in 2 to 5 years of age or over 30 years of age. It mostly results from either the stenosis or occlusion of the big vessels in the brain. And as we discussed earlier, its presentation or the clinical picture depends on the size and the location of the lesion. The risk factors for ischemic strokes involve patients who present with transient ischemic attack, as I said, that it is kind of a warning sign. If someone has frequent acute chest syndrome, because that causes damage to the lungs and leads to reduction in the oxygen supply to the brain. Patients, particularly if they have had acute chest syndrome within the past 2 weeks, then they are more likely to develop stroke within the coming weeks. Patients with persistent hypoxia, either during daytime or during the nighttime, and presence of high or abnormal transcranial Doppler studies and or silent cerebral infarcts. And we'll talk about it in a little while. Whereas hemorrhagic strokes are most frequent in 20 to 29 years of age, it results from rupture of the intracranial blood vessel. Either there is an aneurysm or collaterals, and it presents usually with severe headache and focal neurological deficit. And again, depending upon the size of the bleeding, the presentation may be acute or catastrophic, or it could be very insidious. The reported mortality with hemorrhagic stroke is about 30 to 55% to 50%. So any stroke causes major morbidity or mortality. And the risk factors for hemorrhagic strokes are thought to be older age of the patient, low baseline hemoglobin or acute anemia, high white cell count, and hypertension. So why do patients with sickle cell disease have high risk of stroke? So we talked about how ischemic stroke develops, right? So I'm not going to spend more time on this, but brain, we have 2 big organs in our body, which are very important. One is brain and the heart, where the cells can have no ability to regenerate. So if the cell is damaged, it's damaged permanently, and that leads to major kind of loss of function. And brain relies on constant oxygen supply to maintain the metabolism. Cerebral blood flow is important for brain metabolism and functional integrity. So anytime there is interruption of the cerebral blood flow, it's detrimental for the brain, which leads to hypoxia and cell death. So we all know the pathophysiology of sickle cell disease. So when in an oxygenated state, the red cells, the sickle red cells are kind of happy and they remain the normal discoid shape. However, if there is dehydration, temperature changes, or low oxygen level, the cells become sickled because the hemoglobin precipitates within the cell. And these rigid sickle cells kind of accumulate in the vessel and by itself can cause blockage. That this blockage or ischemia leads to necrosis, organ dysfunction, and acute pain. These cells, because they are damaged, are also undergo breakage, which is called hemolysis, which leads to fatigue, anemia. And most importantly, it also causes endothelial dysfunction. So endothelium is the small lining, the inner lining of the blood vessels. It's really a very smooth lining where the cells typically just glide on. But this endothelium can become angry or activated and then start attracting the cells where the cells stick to the endothelium. Another thing the hemolysis does is it reduces the availability of the nitric oxide. Nitric oxide is important for vasodilatation. So as there is reduction in nitric oxide, the vessels can clamp down or become constricted. However, the sickle cells don't act alone. They kind of, once they are sickled, they recruit other cells. So they recruit white blood cells, they recruit platelets, and they also activate the endothelium, which is the smooth gliding membrane inside the blood vessels. This all leads to, as is shown in this small cartoon, it all leads to kind of a small clot formation there. The sickled red cells also stimulates coagulation pathways. So it activates coagulation proteins, and that can lead to clot formation. It also activates other molecules, which we call inflammatory cytokines. And all those things lead to kind of a big sickled clump of cells. It makes the endothelial lining of the vessels very active and lead to damage. Of note, drugs like hydroxyurea calm down all these processes. So hydroxyurea will increase the hemoglobin F level. So by reduces the hemoglobin S level, keeps the cell well oxygenated. In addition, it reduces the white cells as well as platelets, and it also has the ability to calm down the endothelial surface. So the sickling process can lead to cerebral vasculopathy. So on the right-hand side, you'll see a picture of cerebral arterial circle known as circle of Willis. There are three major arteries which supply the brain to the anterior portion of the brain: the internal carotid artery, the middle cerebral artery, and the anterior communicating artery. These three arteries are the major blood supply to the anterior part of the brain. And then there are posterior cerebral arteries which supply the posterior part of brain along with the vertebral arteries and other arteries. This diagram is important because when we go to TCD, we'll see what TCD actually looks for. So as we talked about, the sickle cell disease vasculopathy affects major arteries of the brain. The endothelial activation leads to endothelial damage. It leads to scarring or hyperplasia of the endothelium, which later on leads to stenosis. The repeated sickling leads to intraluminal or the thrombus formation within the lumen of the vessels, which leads to occlusion. Sometimes the endothelial damage could lead to thinning of the blood vessels, which then balloons out. So the blood vessel has kind of a little pouch which balloons out, known as aneurysm, which is present in about 10% of patients with sickle cell disease.
Dr. Atali?
Sorry?
It's Jennifer here. I'm so sorry to interrupt. I just realized that in the view that we're seeing of your slides, that some of the graphs are appearing quite small. So we're seeing your presenter view still. Are you able to switch out of that?
Okay, so let me see. Can you see it?
It looks the same still right now. If it's not possible to switch, I don't think it's a big worry. Okay. So just to be aware that what we're seeing is the presenter view. So we're seeing your current slide and then the next slide that's to come. But no worries. I think we're still going to be able to see just fine. And please carry on with your presentation.
Okay, sorry for that. It's always tricky. So just, and how are we doing on time, Dr. Brian?
we should be right on track. So it's now 11:30.
Okay, perfect. So we would kind of go over. So the progressive narrowing, so going back to the sickle cell vasculopathy, the progressive narrowing of the arteries kind of leads to small blockage, and it leads to formation of collateral vessels. So this is like if you have a traffic jam on a major road, all other roads take over. So if there is a blockage to the blood supply, then there are new vessels which kind of tuft out. And when these patient undergoes, say, for example, angiography, this looks like puff of smoke, right? So that's why it's called moya moya. Moya moya refers to puff of smoke. And this is called a moya moya syndrome. So about 30 to 40% of patients with sickle cell disease would have moya moya syndrome because of the chronic vasculopathy. And this is typically seen in children and young adults, and it's associated with cognitive decline and or future episodes of ischemia. So several investigators had studied the sickle cell vasculopathy by doing magnetic resonance angiography or MRI studies with angiography. And they identified that for patients who are asymptomatic or who were asymptomatic and who did not have a history of prior stroke, about 10% of them would show vasculopathy. And if you follow them on a longitudinal basis, a progressive vasculopathy within 6 years will lead to 100% stroke evolution. So that, what does that tell us? It just tells us that it's important to follow the patients, evaluate them properly, both clinically and with other investigations if needed. So obviously the next question is that who is at risk for stroke? And when does usually stroke happen in patients with sickle cell disease? So we have the common risk factors, which are commonly seen in adults, as well as these are prevalent in adults with sickle cell disease who develop stroke. So those are like hypertension, diabetes mellitus, hyperlipidemia, heart diseases, especially the atrial fibrillation, and kidney diseases, which then lead to hypertension. In general pediatric population, hypertension is the only and major cause of stroke. But there are factors which are very specific to sickle cell disease. So the level of hemoglobin, the amount of hemoglobin S, the central nervous system vasculopathy, as we saw earlier, and then increased oxygen demand, or if there is a history of prior cerebral infarct. And how these factors may act. They can act in isolation or they can act in combination with other factors. So say, for example, somebody who's got baseline anemia, so hemoglobin level less than 70 all the times, and they are at risk of developing stroke. Or if they have an acute episode of anemia, because so following an infection, what happens is that hemoglobin is our major source of providing oxygen to the brain cells. So you can imagine if somebody is persistently anemic or has acute anemia, then the oxygen supply to the brain is reduced. Similarly, if there is a rapid increase in the hemoglobin, so say, for example, somebody is over-transfused, or somebody had splenic sequestration or liver sequestration, and that blood returns to the body, what it does is that it increases what we call viscosity or thickness of the blood. And anytime there is a thickness of the blood, that can lead to a blockage. And it also leads to increase in the sickling. And that's why you may remember that patients are told to drink a lot because dehydration causes hyperviscosity and may lead to stroke risk. I cannot overemphasize the importance of having some hemoglobin F. So if patients with high percentage of hemoglobin S, as in hemoglobin SS or sickle cell anemia patients, they have much higher risk of stroke. But if there is some hemoglobin F level or fetal hemoglobin, it kind of helps to reduce the risk of stroke by giving more oxygen carrying capacity to the blood. We reviewed the CNS vasculopathy that can predispose to the stroke. Conditions when there is increased oxygen demand. For example, if a person has low baseline oxygen level, persons with obstructive sleep apneas, or if they have an acute chest syndrome, or if the cerebral oxygen demand is increased, as in cases of fever or infection. So any acute event would increase the risk of stroke in patients with sickle cell disease. And anybody who's had prior infarct or silent overt infarct or a silent infarct is at much higher risk of developing stroke in coming years. So how do I know if me or my child is at risk for stroke? And how one can know is by doing the screening testing. So we talked about the type of sickle cell disease. Again, the CSST study showed that a genotype definitely kind of predicts the risk of stroke. Patients with SS are much higher risk of stroke, as shown in this graph. So on the left side, there is patients without stroke. So by 60 years, only about 40% of the patients would be without stroke if they have SS genotype. But at the same time, patients with SC genotype are also at risk of stroke. So by 20 years, about 5% of patients with SC would have stroke, and by 40 years, about 10% of patients with SC genotype would have stroke. Patients with S beta thalassemia, who tend to have higher level of hemoglobin F, have much less risk of stroke, although they do have some risk of stroke compared to normal children. Patients who have alpha gene deletions seem to be a little bit protected from developing stroke. We talked about baseline hemoglobin level, importance of baseline oxygen level, and in general, severity of sickle cell disease. So patients who have multiple episodes of pain crisis, patients who have multiple episodes of acute chest syndrome, which indicates that the sickling is ongoing and sickling is severe, are much at higher risk of developing stroke. Genetic predisposition, so there are many other genes or changes that we cannot detect. But say, for example, in a family, if there is a sibling with stroke, the risk of stroke is higher for other siblings. And of course, if there are other comorbidities, right? So for older patients, if they have kidney diseases or if they have high blood pressure, then that may add to the risk of stroke. And then if they have abnormal transcranial Doppler study or presence and absence of silent cerebral infarcts, then they tend to have a stroke. So let's talk about transcranial Doppler study. What is it and why it is important to have a regular screening done for patients with sickle cell disease? So transcranial Doppler study, or what we commonly call TCD, is an ultrasonographic study, which is a non-invasive rapid test. So your child does not need to be sedated for that, or you don't need to be sedated. It's quickly done. It is a major invention in the care of sickle cell disease patients. It measures cerebral blood flow in the major vessels. It has got very high sensitivity and specificity. That means it can detect patients who are at much higher risk of stroke very reliably. It is an important tool, and that is why it has become like an important or major tool for screening to identify patients who are at high risk for stroke. We reviewed earlier that the most frequently affected arteries are intracranial, internal carotid artery, the middle cerebral artery, and anterior cerebral artery. So as you can see, when somebody is doing an ultrasonographic, so this is where the probe or the sonographic instrument is kept just above the ears, and it then looks at all these arteries. The studies have shown that TCD, the vessels tested by this and the cerebral blood flow measured by this, can identify flow abnormalities before even the magnetic resonance arteriography can detect the abnormalities in the flow. A study done by Adams et al. Showed that there was a high association of TCD and cerebral vasculopathy. And subsequently, the stroke prevention trial, which we'll learn more about from Dr. Williams, provided evidence that patients who are shown to have a very high cerebral arterial blood flow, if they're given chronic transfusion therapy, the stroke risk is reduced significantly. So when we are doing the TCD, we look at the flow velocities, and the TCD flow velocity predicts risk of stroke. There are many velocities. So if you ever see the report of TCD, there are many velocities that are reported, but what we are looking at is the time average mean of maximum velocities. And various studies, there are many studies who have looked at that, and what they have shown is that the time average maximum mean of maximum velocities, it is a mouthful, in middle cerebral arteries or distal internal carotid arteries are strongly associated with the risk of stroke. And the studies have identified 3 cutoffs. So if the velocity is less than 170 centimeter per second, then that is normal. If the velocity is over 200 centimeters per second, then it is identified as an abnormal or high velocity. And patients with these high velocities are at 6 times higher risk of stroke than those who have less than 170 centimeters per second. And is shown to be an indication for chronic blood transfusion, which reduces the risk of stroke by 90%. So anybody in between these velocities is called borderline. So 170 to 199 centimeters per second. So what happens to this group of patients? So patients with borderline, or what is called as conditional TCD velocities, they are also shown to be at high risk of stroke. So somewhere in the range of 2 to 5% risk per year. So some people would divide this risk, the velocities, between low conditional, meaning 170 to 185, or high conditional, between 185 to 199. The conditional TCD velocities over a period of time may normalize, stay the same, or they may convert to abnormal. So Hankins and al. Conducted a study using stop data and showed they looked at patients who had no silent cerebral infarcts and who did not have past history of stroke, but who had a high they had borderline or conditional TCD velocities. And what they showed is that if untreated, there is a high conversion rate from borderline to abnormal TCD velocities. And other studies have shown, so overall about 30 to 55% of patients with conditional velocities will convert to abnormal TCD velocities if left untreated. So the predicted risk of stroke, as shown by the STOP study, is that if you have about 74%, so just to kind of let you know that majority of the patients with sickle cell anemia would have normal TCD velocities, and their risk of stroke is very low. About 9 to 10% would have abnormal TCD velocities with a very high risk of stroke, but that can be reduced by chronic transfusion therapy. And about 17% would have conditional or borderline velocities who could be watched carefully and then appropriate actions taken. So we talked about higher or the normal velocities, but what happens if the TCD velocity is low, for example, less than normal or 70 centimeters per second? And as I said, that studies done in Africa or India kind of give us a snapshot of what could be happening if a patient with sickle cell disease is left without proper follow-up and proper therapy. So this was a paper which was recently published from Tanzania. Kija et al. They studied about 200 Tanzanian children without history of stroke and with TCD velocities. about 39 patients, so majority, about 20% of them had no flow or a very low velocity flow. And 8 or 20% patients each had either prior seizures or neurologic weakness. And 6 out of 24, that is 1/4 of the patients with no flow, had silent infarcts. And about 32% of patients, so only about 28 patients out of 39 underwent MRI studies. And 9 of those, so that is 32% of the patients, showed abnormal findings on the MR angiography. And what is very concerning is that 5 out of those 29 patients who did not have any flow developed overt stroke. Studies like this, as well as few case series in the US, have shown that low velocities points towards another type of abnormal TCD and needs to be taken very seriously. These low velocities or absent velocities are indicative of severe stenosis or occlusion of the larger vessels. So one needs to have a confirmatory repeat TCD testing at shorter interval, and people choose between 1 to 3 months. And if they have persistently low velocities, additional evaluations of MRI or MRA is indicated. So what are the recommendations, current recommendations for TCD screening? So annual TCD screening starting 2 years of age till 16 years of age is recommended. For patients who have borderline TCD velocities, we repeat within 3 to 6 months. And patients with high velocities do MRI or MRA and MRV and consider transfusion therapy after discussions with the family. Please note that patients who do receive blood transfusion within 3 months prior to TCD testing, you may have a falsely low TCD velocities, because we know that blood transfusion normalizes the TCD velocities. Also, patients should be preferably in their baseline health status, because any infection, low hemoglobin will increase the velocities falsely. So one doesn't want to make recommendations of quite an invasive treatment like chronic blood transfusion based on velocities, which may not be reliable. And hence, whenever we have high velocities, we look at it very carefully and repeat the testing to make sure that that is really a persistent high velocity. So what is a silent infarct? It's the most common neurological entity in patients with sickle cell disease. The definition of silent cerebral infarct is quite complex, I would say. It's a combination of neurological examination by a trained neurologist and a neuroradiologist evaluating the scans. So you should have abnormal MRI findings of the brain where there is at least a 3 millimeter lesion in the greatest diameter, which is confirmed on 2 views, with normal neurological findings and without any prior history of physical findings consistent with Overt Stroke or physical findings which might be explained by those lesions. And these patients are kind of categorized are having silent cerebral infarct. It's quite prevalent, and I hope you're able to see this graph correctly. But as early as 1 year of old patients are shown to have the silent cerebral infarct, and over a period of time, the risk of silent cerebral infarct increases. It starts at about 10% at 1 year of age and goes on to have about 27% by 7 years of age and 37% by 14 years of age. And it continues even in adulthood. So the studies, there are not many studies evaluating silent cerebral infarcts in adult population, but about 50% of 30-year-old with sickle cell anemia would have the silent cerebral infarct. So this is a continuous process. Although it is most common in patients with hemoglobin SS, About 3 to 38% of patients with beta thalassemia and about 5 to 31 patients of hemoglobin SC disease are shown to have silent cerebral infarcts. So it would be safe to presume that about 1/3 of patients with sickle cell disease would have silent cerebral infarcts. And silent cerebral infarct is a risk factor for additional neurologic events. About patients with SCI or silent infarcts are 14 times at higher risk of developing stroke, and they are also at risk of having progressive silent infarcts. So on this graph on the right-hand side, the MRI of patients, when the MRI was normal, the risk of stroke was very little, whereas patients with silent infarct, the risk of stroke over the years was much higher. Also, about 25% of patients with prior silent infarcts developed new or enlarging infarcts compared to only 2% of patients without silent infarcts. What are the risk factors for developing silent infarcts? Again, low hemoglobin. So studies have shown that a low baseline hemoglobin of less than 7.6 or 76 grams per liter would can increase the risk of silent infarcts. So silent infarcts, I mean, this was a very good studies conducted by Ford et al. And Dr. Debon's group, who's an expert in neural disease in sickle cell disease. So 90% of the children with sickle cell disease would have silent infarcts in a very small area of brain, which is called a watershed area, where the cerebral blood flow is at very low level. So this is the silent cerebral infarcts are thought to vasculopathy of smaller vessels rather than larger vessels. And because the cerebral blood flow is very low in this area, you can imagine factors which would affect oxygen carrying capacity of the blood, like the low baseline hemoglobin or high systolic blood pressure would increase the risk of developing silent infarcts. In addition, high white blood cell count, male sex, prior seizure history, or intracranial stenosis also increases the risk of developing silent infarct. In addition to the increased risk of stroke, what are the clinical implications of silent infarcts? The most important clinical implication, I think, is the cognitive deficiencies. And these cognitive deficiencies occurs in various areas of or brain executive functions. So it affects the attention, it affects working memory, processing speeds, and reasoning and comprehension. Dr. Debon and his group reviewed at around 8 studies which were done in patients with sickle cell disease without any neurological problems, patients with sickle cell disease who have silent cerebral infarcts, and patients with sickle cell disease with stroke. And some of those studies compared the cognitive functions as measured by full-scale IQ or intelligent quotient testing by neuropsychological evaluation, and they compared that to patients with similar ethnic background who did not have sickle cell disease. And as shown in the graph on the right-hand side, patients with sickle cell disease without any neurological findings had significantly lower intelligent quotient, whereas those intelligent quotient compared to the normal controls, sickle cell disease with silent lesions had much reduction to about 80 points, about 10 points lower than the normal controls. And patients with sickle cell disease with stroke had average intelligence of about 73. So almost 15 points lower than normal control patients. And this is an ongoing, so reduction in the cognitive functions for sickle cell patients is an ongoing functions. This leads to poor scholastic grades and poor academic achievements, especially in math and English. Another study looked at the proportion of students who required special services at school, or who failed a grade. So here the investigators compared the siblings of patients with sickle cell disease who did not have sickle cell disease to patients with silent infarcts and patients who developed stroke. So about 6% of the siblings without sickle cell disease either had or required special educational support or failed a grade. There's 27% of patients with silent infarcts either failed a grade or required assistance in the school. And that percentage increased to about almost 60% in patients with sickle cell disease and stroke. So it's very important to identify. If a patient has developed new cognitive or school difficulties, or if patient has a persistent cognitive defect, to make sure that they do not have underlying silent infarcts. And why is it important? Is that because we can implement corrective processes, either help in the school by giving some special educational assistance or vocational guidance to adult patients. So what happens if somebody has a high abnormal TCD and also developed silent cerebral infarcts? So patients compared to only abnormal TCD alone, if they have both abnormal TCD as well as silent infarcts, they are significantly at higher risk of stroke. So a STOP trial showed that 15 out of 29 patients, so almost 50% of the patients with abnormal TCD and silent infarcts developed stroke, compared to only 9 out of 42 with only abnormal TCD. And those patients with both abnormalities, abnormal TCD and silent infarcts, are much higher risk of progression of silent cerebral infarcts, which, if they are progressed, will increase the risk of stroke. So how do we screen patients with silent cerebral infarcts? The most recently published American Society of Hematology guidelines recommend that early school age children should have at least one-time MRI screening. And the panel also recommended that adults should be screened at least with one-time MRI to identify patients who have silent cerebral infarcts. So in summary, how do we screen patients with sickle cell disease for the stroke risk? So we recommend TCDs, transcranial Doppler studies, with annual studies, annual TCD between the age group of 2 to 16 years. Those who have high or abnormal TCD, they would require chronic transfusions. If they have conditional or low TCDs, repeat and check if they need additional imaging studies like MRI, and do any additional testing that is needed. They also recommend developing a simple cognitive screening both for children and adults. And this could be at every visit, inquiring about how are they progressing. If it is a young child, how are their milestones? In early school, asking them how they are doing in school. Are they finding any school difficulties, or at home, are they finding any attention or memory defects? If any of this screening identifies concerns, then a proper neuropsychological evaluation is indicated. And MRI screening at least once in early school age children and in adulthood, and if necessary, then subsequent follow-up MRIs. So then, going back to our initial case, the next questions the parents ask are, how can you help my child? And at this point, I'm going to hand it over to Dr. Williams. So I'm going to
Thank you so much, Dr. Atali. While you're doing that handover for the screen, just want to say thank you to everybody who has been posting questions for our Q&A. Please feel free to keep posting those questions. I think that we're going to have a great discussion with Dr. Atali and Dr. Williams. My work is mostly in the adult world. I'm an emergency physician, so I know I'm learning an awful lot from this session, and I'm sure it's proving useful to all of you in the audience. So thank you again to Dr. Atali and Dr. Williams. Dr. Williams, doing okay with starting that screen share? There we go. Excellent. Yep, we're starting to see your screen there.
So how is a stroke actually managed? So there's the immediate part of the management where you initially suspect a stroke, but you may not actually have confirmation yet. Then you would step to the intermediate phase of stroke management, where you're now confirming that there has indeed been a stroke, and then proceeding to longer term management for stroke. So management of acute stroke. One of the important descriptors for acute stroke management was coined by this physician a number of years ago: time is brain. So the idea is you want to institute corrective and supportive management as soon as possible. Dr. Atali mentioned, I think at several points, this concept of loss of blood flow and the importance of time to prevent damage to cells. So in 1 second, 32,000 brain cells will die if they're deprived of appropriate oxygen and nutrients. So once a patient presents with an acute neurological deficit for which a stroke could be the explanation, so you don't know they have a stroke yet because you haven't done the imaging, there are some initial supportive strategies that one would implement. So starting off with involving the brain doctors, the neurologists, and the hematology and the blood doctors, connecting in with the radiologists, the neuroradiologists, to assist with getting imaging quickly and the appropriate imaging quickly, and then transfusion medicine, because as you've already heard, transfusion is a significant part of stroke management, which we'll touch on a little bit more as well. So brain imaging needs to be done to confirm your suspicion of this acute neurological deficit being related to an underlying stroke event. In addition to the imaging tests, whether that would be an MRI or a CT scan of the brain, you would do some blood analysis, which would include CBC, getting a sense of what the patient's hemoglobin S level is, their coagulation profile, to see if they have any signs that they're at increased risk of bleeding, and just a basic blood profile on the patient. Oxygen is always a part of sickle cell care because you want to optimize a patient's oxygen if they're presenting with any event that could be related to sickling, because we know hypoxia or low oxygen, bad for brain cells, bad for sickling. And so you want to improve that as much as possible immediately. Similarly, fever may be representative of an underlying infection. And we always make that assumption in sickle cell care, that if we see a patient who is febrile, we assume they have an underlying infection that could be related to a bacteria, and so we'll cover with antibiotic treatment. So bringing down the temperature effectively with antibiotics and managing with antibiotics for the postulated underlying bacterial source of fever. So an exchange transfusion is what would be done as soon as feasible in a patient presenting with an acute stroke. Once you've confirmed that. And this is really a process. You can see the young man there, demonstrating he's attached to an exchange machine, which in this case is connected to an arm blood vessel. Often when a patient presents to the emergency room, may not have the luxury of being able to get arm vessels, and so often a groin vessel or a neck vessel may be used. But the idea is to remove the sickling cells, so replacing the patient's own blood cells, which are the source of the disease, the sickle cell disease, and replace that with normal donor red cells that don't have sickle cell disease and therefore will not sickle. So you're really trying to shut down the sickling process as soon as possible to restore normal blood flow through the areas that have now been compromised. So exchange transfusion for stroke and sickle cell disease has been around for a number of decades, but it's really a more recently described intervention. It was first described in a case in 1983 from a child presenting to a hospital in Philadelphia, very similar to the case that I started off this session with. This was a 5-year-old boy in this instance who had sickle cell disease and presented with loss of vision, fever, abnormal gait, headaches, and staring episodes. He was given a simple transfusion first, which is simply what this child is having here. So is connected to the basic intravenous and has donor blood hanging, and you're just infusing red cells. And following that procedure, he had this exchange transfusion where they exchanged or altered a much larger volume of blood than one can alter by giving a top-up or a simple transfusion. You can see the difference in the volumes there. So in essence, it can be done manually, so not on the fancy machine all the time. As I showed in the prior slide, you could sit by the patient and manually exchange them as well by connecting them to dual IVs would be more efficient, but connecting them to an IV where you would pull blood off into a syringe and give blood back. So pulling off their blood, which has the sickling process ongoing because of the sickle cell disease, and replacing it with donor blood that won't sickle. In this young man, at the conclusion of the exchange, he had a hemoglobin S that had been reduced from 95% prior to starting to 12%. His hemoglobin had increased from its usual ballpark value of 60 to 70 to 143. He was alert. He regained his vision and his neurological exam completely normalized. So this is what was done for case AB. So she presented to an outside hospital, actually, when her CT was done. She was then transferred fairly quickly to Sickle, received an exchange transfusion and antibiotics in hospital. Her paralysis improved in the subsequent few days in hospital. And at time of discharge, a number of days later, she walked out of the building with essentially almost complete resolution of her neurological deficits or her paralysis. So acute management of stroke is about supportive care, decreasing or halting the ongoing sickling process as quickly as one can to salvage as much brain as possible. So the longer the sickling process goes on, the more brain cells potentially are going to be damaged or destroyed. And the way to effectively do this is through an exchange transfusion. Then you would move to the subacute care of a child or an adult with sickle cell disease who presents with a ischemic stroke. So a stroke that's related to a blockage of blood vessels and loss of blood flow to that area. Secondary stroke prevention is very important because once you have a stroke, the chances of you going on to have another stroke if no interventions are offered is very significant. So recurrent stroke in 60 to 90% of patients will occur without therapeutic intervention. In fact, some would say it probably looks close to 100% if you wait long enough. Once you've had a stroke, your chance of having another stroke is very large. Initially, after your first set of imaging, to detect or diagnose your stroke, there is a recommendation to do follow-up imaging within a couple of weeks to a month, and that's to try to gauge the more steady state effect of what the stroke event may have been. Because at the time that the individual presented with the acute stroke, the true extent or total extent of the damage may not yet have occurred. And so that first image may not be representative of the entirety of the stroke. And so this follow-up imaging will give you a better sense of the areas of brain tissue that have been damaged. If an MRA or if a vessel evaluation has not been completed up front, then that would need to be completed later. So MRI can be done to look at the brain tissue. The MRA looks at the brain arterial vessels, and an MRV would look at the veins. So often when children would present, we would do the MRA with the MRI, but it doesn't have to be. You could do it separately, but it is an absolutely essential part of the management that it's done at some point, because as Dr. Athali has already alluded to, if you identify a vasculopathy, so if there is a blood vessel that has this moya-moya phenomenon or this narrowing phenomenon, or a change in the blood vessel from what a normal blood vessel would look like, the likelihood of that individual going on to have further neurological events is 100%. We would also screen for other comorbidities that may have contributed to the stroke. So we're attributing the stroke largely to the sickle cell process because, as you've heard, sickle cell disease increases your risk for stroke. But certainly if you have additive other comorbidities that also present with a stroke risk, then your risk is even more escalated. So having hypertension, diabetes, elevated cholesterol or hyperlipidemia, it would be important to identify those things to take corrective actions because those are also contributing to the future stroke risk for that individual. Similarly, if you have an intracardiac defect called a patent foramenovaly, which is a tiny connection between two of the chambers of the heart, and so blood can shunt from the right side to the left side, which it normally wouldn't, that is also potentially a source of clots or tissue or and blood cells mobilizing through the blood and going to the brain. So case AB was the young lady presenting with stroke at 3 who got exchanged and did very well, and at time of discharge had resolution of her neurological deficit. Here's another case that I'll share. So this is CD, so also a term baby, uncomplicated pregnancy, healthy young child. Sickle cell disease was diagnosed at 7 months of age, entirely normal development. At age 4 years, he develops leg pain and sudden onset of vision loss. He's taken to his local hospital and on arrival becomes unconscious and develops a right-sided paralysis. His brain imaging shows a stroke. This was not in Canada, so this child did not receive an exchange transfusion because it was not available at the hospital that he was at. He had ongoing paralysis, and at the time of discharge home, he had still a dense right hemiparesis or right-sided paralysis of his arm and leg. So what's the natural history of stroke and sickle cell disease? You've really essentially heard it so far in many of the things that we've talked about. It's that once you have a stroke, you're likely to go on to have another stroke. And in particular, if you have a vessel abnormality or vasculopathy, you're definitely going to have another stroke event. So this is one of the older studies that really first described that natural history of stroke in sickle cell disease. So they looked at 35 patients who presented with stroke events. 23 of those were ischemic stroke, so the blockage types of strokes. 11 of those were the bleeding types of strokes, so intracranial hemorrhage strokes, and one was an embolic phenomenon, so a clot that moved from elsewhere in the body to the brain tissue. They were treated with supportive care, meaning fluids, oxygen, transfusion, but not exchange transfusion. So top up or simple transfusions, but not exchanging a large portion of the patient's circulating blood volume. They observed these patients for the subsequent 9 years and saw a reoccurrence rate of 67%. There was a clustering of recurrence in the first 36 months. So 60% of that 67% recurrence rate occurred within the first 3 years. And 12 patients went on to die because of their stroke. So a prophylactic transfusion program is recommended for children or adults with sickle cell disease complicated by a CNS event or a central nervous system infarction or stroke. Um, Again, this is one of the first studies to really describe the benefit of that process. So this is back in 1976, where they looked at 15 patients with sickle cell disease and stroke and initiated them on prophylactic transfusion program for at least 9 months or longer, and then followed them into the subsequent months. 14 of those 15 patients had no further episodes of stroke. Of the 2 treatment failures that they did observe, it was in patients where there was one patient didn't appear for their transfusion. So they did not come and receive their transfusion therapies and went on to develop. One patient had facial twitching and aphasia, so loss of speech, and another patient had 2 subsequent episodes, both of which occurred when there was a longer gap between the transfusions and the level of the normal hemoglobin was only 20%. So they had basically gone back to being their more native state, which is largely more S because of the sickle cell disease, and not attending for transfusion visits. So periodic transfusion for sickle cell anemia and stroke events is a good way to prevent future stroke events in those patients. It's not perfect, but it does offer significant improvement compared to the natural history of those stroke events. Again, this is one of the very early studies that first reported this back in 1979, and they took 12 patients who'd had stroke events and looked at what happened in the period of time before they received transfusions and then after they had received regular transfusions. Their transfusion protocol was to target reducing their S percentages to under 25% and bring their hemoglobins up to 100 to 120. And you can see the stroke events are labeled in the little arrows there. So before transfusion, you can see the number of arrows that you're seeing. And after transfusion, it's not that the arrows are 0. So there were patients that had events. Noticeably, this particular patient with the 2 events also occurred when they did not have transfusions. You can see the white there. They didn't get transfused during those periods of time where they had those events. But you can see a significant decrease in the number of arrows that you're seeing. And it's really occurring when the patients are not having their transfusion visits. So sickle cell stroke effectively treated with red cell transfusions. And you can see the reduction in the probability of a new stroke event. So probability of recurrence is on the vertical axis here, and time out from following the patients. These are the patients that are transfused. These are the patients that are not transfused. And so the majority of the patients with transfusion do not have another stroke event versus the majority of the patients without transfusion, if you wait long enough, will have another stroke event. So what do you do if you can't transfuse the patient or the patient declines transfusion therapy? So if you cannot complete regular blood transfusions or there is a patient preference not to be transfused, hydroxyurea would be an alternative option. So it's not as effective as regular blood transfusions for secondary stroke prevention, but it's better than the natural history without any sort of therapeutic intervention. So it's considered a reasonable option. One of the studies that was done more recently, so more than 10 years ago now, was looking at in patients that had a stroke and you've commenced them on a transfusion program, could you ever take them off? So once you've started transfusion, are you now obligated to lifelong transfusion protocols, which really has been the thinking. And so this was a study in an attempt to see, is there a viable alternative for patient management apart from transfusion? So they took 134 patients that had had a stroke and randomly assign them to either continue on their transfusion program, so 67% in that arm, versus 67 patients, sorry, not percent, 67 patients, so half and half, to receive hydroxyurea and blood removal to correct the additional iron that they had on board from the red cell transfusions that they received. In the transfusion arm, no stroke recurrence. In the patients that received hydroxyurea, 10% had a stroke recurrence. And you can see that's separating out on the curve here. So the patients that are on the hydroxyurea versus the patients that continued on the chronic transfusion. So chronic transfusion is preferable to hydroxyurea, but hydroxyurea does still offer some benefit, although a number of the patients did still go on to have subsequent strokes. So 7 of the 67 had neurological events, and there was 1 death due to hemorrhagic stroke in that arm. If we look at all the studies that have been done, this is a publication from 6 years ago now, looking at types of therapy that have been implemented for stroke prevention in patients with sickle cell, and looking at the benefit of the different therapies. So hydroxyurea therapy versus no therapy versus transfusion, and the studies that were completed there, you can see that the incident rate of stroke recurrence with no therapy, so the natural history, very significant number. Hydroxyurea treatment, it's better than nothing, but it's not as good as blood transfusion. And importantly here, blood transfusion is not perfect. There are still patients that, despite blood transfusion, will go on to nevertheless have further stroke events. So transfusion is care, but not cure. So it doesn't eliminate the process. And this again, Dr. Athalia touched on, highlights the fact that stroke events can occur despite compliance with therapy and regular blood transfusions once you've had a stroke event. This was a study looking at patients who had regular blood transfusions after a first stroke, and then watched to see what happened over time as you can continue that blood transfusion therapy. Of the 40 patients that were analyzed, 33 did not have further stroke events, but 8 of them had silent strokes. And really only 21% did not, 21 patients did not acquire some form of new lesion on their MRI. So again, just highlighting the fact that transfusions aren't perfect. Once you've had a stroke, this is a devastating thing. It has huge implications in terms of your future stroke risk, despite whatever therapy is offered. And importantly, this concept of the vasculopathy and the abnormal vessels. So if you have a vasculopathy, your outcome is much worse than if you don't have a progressive vasculopathy. So again, this is looking at new or silent cerebral infarcts in children that are on chronic transfusions after having a first stroke. And if you have a vessel change here, then you're much more likely to get new events. If you don't have any vessel changes, you still get new events, but not at the rate that the patients with vessel changes do. So what else can be offered to patients? Since we know having vessel abnormalities is a huge predictor of poorer outcomes, and transfusion therapy by itself is not curative, and patients, despite transfusions, will continue to have potential neurological events, although at reduced rates. There are surgical options for patients with the moya-moya or vasculopathy identified. So I'll tell you about another case from our clinic, case EF. So this is a young man who we met at 14. He had been diagnosed with sickle cell via amniocentesis, and so had always participated in comprehensive sickle cell care follow-up. At age 14, he has stroke risk screening with transcranial Doppler ultrasound that identifies him as high risk for future strokes. His brain MRI showed multiple silent strokes. And he was offered chronic transfusions. He completed 2, transfusions and then was lost to care for a period of time. 2 years later, at age 16, he develops 3 days of headache, decreased energy, fever, then has facial twitching, drooling, becomes incontinent, loses the ability to swallow, loses the ability to speak, and has left-sided weakness, comes into hospital, and his brain imaging shows stroke and this vasculopathy and this abnormal vessel. So from what you've already heard from Dr. Athali and myself, that once you have an abnormal transcranial Doppler, plus you have silent strokes, it's in the neighborhood of 50% that you're going to have a future stroke. And he, in fact, went on to develop a vasculopathy and came back with a stroke event. So he was offered surgery to decrease his stroke risk. And the kind of surgery that he had completed is something called a pial synangiosis, which is done for Moya-Moya syndrome in general, and also offered to patients with sickle cell disease who have Moya-Moya syndrome. And surgical revascularization is a bit of like irrigation. So it's bringing water to the desert. So if we think of water as essential for crop and plant growth, and we think of blood as essential for normal brain functioning and oxygen supply. You see the oasis here and the water coming to the desert area and having lush vegetation right adjacent to the water. What a pial synangiosis or revascularization does, this is a CT angiogram reconstruction. What is actually done is you take the temporal artery, so facial artery vessels, and you flip them up after drilling little holes in the bone and the skull of the patient to allow, and you lay the vessels down. So you take the arteries that would normally supply the face, drill a little hole in the bone, flip the arteries up, and allow the blood vessels to really just sort of grow into the brain tissue. And so it's bringing in blood supply that was not there before. And so hopefully protecting that area of brain that was relatively starved of oxygen and likely to go on to stroke in future by giving it some more blood supply or more irrigation, so to speak. The outcomes for this procedure are quite good. And so looking at the probability of being stroke-free after one of these procedures, this is looking at 53 children. Again, it's not perfect, but above 90% of children did not go on to have another stroke event. The next thing that can be considered for secondary stroke prevention would be stem cell transplant, bone marrow transplant. So due to the progressive nature of infarct recurrence, as we've talked about, having had a stroke, you're in a negative prognostic situation where the likelihood of having another stroke is significant moving forward. Blood transfusion therapy has benefits, but it's palliative. It's going to stave off the stroke for a certain amount of time, but the likelihood with time is that another stroke event may occur. We know that offering curative therapy can reduce the recurrence rate of stroke much more than blood transfusion therapy can. For patients that don't have sibling matches, because of course the most ideal donor for a transplant would be a brother or sister, so a sibling that matches, and not everybody has that, so probably less than 20% of patients that would benefit from a transplant would actually have a match in their family. Alternative donor transplants are being explored, such as unrelated donor, so matched unrelated donor, umbilical cord donation, or haploidentical transplant. So that's transplanting from someone who's not identical as a matched sibling. So a parent, for example, would be an example of a haplomatch or a half match that one might be able to use for transplant. So I'll share this because this is in the public domain that many of you may have come across. So this picture is of a transplant physician in Calgary and a sickle cell patient, Cordelia, who had strokes starting at age 6 months and had a number of strokes in childhood years. Her sister, who was her matched donor, and she had a reduced intensity type of transplant, so much less side effects and complications than traditional transplant had offered. And this was a very lauded in the media when this occurred. So there are other options that could be considered for stroke prevention, which would also cure the sickle cell disease. So what would be the intermediate and longer term management of stroke? So we're really focused so far on prevention of another stroke, and that's a huge part of it. And that involves transfusions, aspirin, which I didn't detail too much, but that's a standard additive protective medication that would be offered or recommended to patients once they've had a stroke for the beneficial effect. Revascularization surgery, we've touched on, or curing the sickle cell disease to therefore eliminate the chance of having another sickle cell associated stroke. Importantly, supportive services for whatever residual deficits may remain as a result of the stroke will be very important as well. So how does a stroke affect patient and family? So AB was our young girl who gets an exchange transfusion and has resolution of her deficits and does well. CD did not have an exchange transfusion. It wasn't available at the center he was treated at and does have residual motor deficits, so has residual paralysis. Both children are behaviorally very different children after their strokes than they were before their strokes when you speak to their families. CD had to repeat a school grade. Both required adaptation to their school programming, so they went on individualized educational plans. CD required physiotherapy. He uses an orthotic to help with his foot positioning when walking. He has regained some functionality, so he's not completely paralyzed, but walks with a limp, has reduced mobility and use of the arm that was affected by that stroke. So physical rehabilitation is an important part of stroke care for most patients. So if you're not fortunate enough to have complete resolution of the physical deficits, then rehabilitation services would definitely be a part of the intermediate and potentially even longer term care to optimize mobility in particular. So education remediation will be in the form of doing the cognitive testing to establish what's the level of cognitive impairment that an individual actually has, to establish really appropriate expectations for what the patient would be able to do and achieve on their own, and the needs for the family and the family supports that will need to be put into place. For children, the cognitive testing allows you to develop an individualized education program for them, and it will help them to meet academic standards, which may need to be adapted for their potential. Adults, as Dr. Athali described, for vocational counseling and job assistance to sort of gear towards what would be feasible and doable. And for patients that end up having quite diminished IQ scores and loss of planning and executive functions as a result of the stroke, then additive supportive services will need to be put into place to even allow them to come to appointments when they're no longer being in their parents' home, for example, so as young adults, and to facilitate adherence to medication, all of the things that will hopefully help them or protect them from having another stroke, they will need assistance with participating in. So the bottom line, immediate impact to patient and family is the initial event and hospitalization, which can be quite traumatic. Longer term, there may be long-term potential behavioral changes. There's the residual physical or cognitive impairment that may be there, the impact on school, work-related performance, and then the individual's own need to adapt to what those changes may be and the family adapting around that. So having said all that, then really prevention is the best treatment. So if you could prevent a stroke before it happened, that is far and away better than dealing with the consequences. So GH is a young lady that we saw in clinic as well. She was diagnosed with stroke in her first year of life. She had normal development. She was an excellent student, loved math. She would tutor younger children in math. At age 7, she was identified by the transcranial Doppler to be at high risk for stroke. She was offered transfusion, declined transfusion therapy, and started on aspirin. At age 8, so about a year later, she is admitted for a pain episode. On the second day of her admission, she becomes disoriented. She loses the ability to write, do math. She can't see her finger. She can't tell left from right, and she loses speech completely. Her brain imaging shows a stroke. And so we've already touched on the fact that transfusion reduces the stroke risk quite dramatically. So by reducing the sickle cell percentage from above 80% to less than 30%, you reduce your stroke risk by 92%. This is significant. This comes from the STOP trial, which Dr. Athali had touched on. So in this study, they took patients who had these transcranial Doppler ultrasound screening tests, almost 2,000 of them. And of the ones that had abnormal TCDs on 2 occasions, those were 206, they put them either in standard care, which was coming to clinic, having routine visits, versus transfusion. Of the patients that were transfused, 1 developed a stroke. Of the patients that were not transfused, 10 developed a stroke and 1 developed an intracranial hemorrhage. The trial was actually stopped early, so before the completion of the study, because of this incredible discrepancy between the 2 arms. And this is how transfusion became the standard of care after an abnormal TCD to prevent stroke. And in fact, after the STOP trial was published, if you looked at what happened in the population, after the publication of the STOP trial, looking at the stroke rates in children with sickle cell disease in California, you see what happens. So once transfusion started being implemented as a standard of care, strokes just plummeted in terms of their incidence in that state. And this would be reflective of anywhere as well. So now you put them on transfusions to prevent getting that first stroke, and it works pretty well. But does that mean you have to leave the individual on transfusions forever, for a few years? How many years? So the STOP 2 trial was done to try and answer that question. Could you ever withdraw transfusion therapy once you had implemented it? So the STOP 2 was looking at discontinuing prophylactic transfusions that had been implemented to prevent stroke and sickle cell disease. Here's the bottom line of the study. So if you looked at patients that were basically randomized again, so randomly allocated to either continue transfusions, which they've been placed on, or stopping the transfusions. If you continued transfusions, you continued to be protected from stroke events. If you stopped transfusions, you started having stroke events. So this discrepancy between the two groups. So that would mean you would need to leave patients on transfusion for an extended period of time. Transfusions aren't ideal, they're problematic. And so the TWITCH trial was a later study that looked at, could you take these patients who'd never had a stroke, but are at high risk of stroke, and ever at any point get them off of transfusions and do something else that would also protect them. So this was switching the same set of patients to hydroxyurea versus continuing transfusions. So 121 patients who were on transfusion for stroke prevention, you either continued their transfusions or put them on hydroxyurea. And you can see what happens is that in those patients that went on, there were TIAs, so transient ischemic attacks are transient damage to the brain, but not strokes, occurred in 3 instances in the hydroxyurea arm and 3 instances in the transfusion arm. So this again sort of changed practice, because it said that after a period of time, if you instituted an alternative therapy, you could get these patients off of transfusion, and hydroxyurea would be that alternative therapy that you could offer to families. Transplant will also effectively reduce the risk of stroke once you've had a patient identified as being at risk of stroke. So this is looking at patients who have abnormal transcranial Doppler ultrasounds and moving forward to have either standard care, which is transfusion, or going ahead to transplant. And you can see that the transplantation actually brings down the velocity on the TCD to a much better extent than the transfusion does. So again, an alternative for patients that are fortunate enough if they have a sibling match. There was no difference in ischemic stroke rates. There was, no ischemic stroke in those patients that were transplanted, and they did as well as the transfusion arm. So again, it's an option. Their quality of life seemed to be better at 3 years in the transplant group, and also better at a year in the transplant group. So not having to come to transfusions on a regular basis also improves your quality of life. So transfusions are a big part of how we treat, manage, prevent stroke. So we can do it when the TCD is abnormal to prevent the first stroke. We can do it after the stroke to prevent the next stroke. And then with more stroke, you can continue to do transfusions. But how about anything that you could do before they even identified as being at risk of stroke? And clearly we wouldn't put all patients on transfusion. That would not be acceptable and not really appropriate use of resources. But what else could you do if you can't transfuse everybody? This study looked at putting patients on hydroxyurea. So it took patients and put them on hydroxyurea and then watch what would happen with their transcranial Doppler ultrasounds. And you can see that hydroxyurea arm is here in red and the observation arm is here. So these are patients that are not being treated with anything, just coming for clinical follow-up. You can see that the hydroxyurea prevents the chance that you go on to develop an abnormal transcranial Doppler result versus the natural course of observation. So again, starting hydroxyurea early can prevent the development of abnormal TCD and all of the sequelae in terms of increased risk for stroke and secondary stroke once you have your first stroke thereafter. And the change in TCD that was seen, again, significantly different. So being on hydroxyurea does effectively reduce your transcranial Doppler velocity compared to just observation. So silent strokes, this is sort of the last one. So Dr. Athali talked about this already. So here's a kid with silent stroke, reflective of the educational problems that he may have, the tiny lesion that's there in the brain, but not any overt, necessarily physical signs that one can see. The silent infarct transfusion study looked at transfusing patients who had silent strokes. And you can see the difference in the transfusion arm versus the no transfusion arm here. So these are patients that didn't have any event. These are the transient ischemic events, silent strokes, and overt stroke. So if you were transfused, you had minimal overt stroke and far fewer silent strokes than the patients who had no transfusion. So transfusion can prevent further silent stroke and overt stroke in children who've already had a silent stroke. So how do I prevent getting a stroke? So once you've already had a stroke, so we're talking secondary prevention, chronic transfusions, curative therapy for sickle cell, such as transplant, aspirin, and surgical options. Primarily, if you're wanting to prevent a stroke before one has occurred, you want to identify those patients who are at greater risk and intervene appropriately. So transfusion may be appropriate if the TCD is abnormal. Curative therapy would also be an option if you have sibling matches for transplant options. And lastly, optimizing your sickle cell care. So hydroxyurea would be a part of that, but also general health prevention. So healthy living habits, so eating a healthy diet, maintaining a healthy weight, being active, not smoking, and limiting alcohol use are all general health things that are also stroke prevention things. Incorporating sort of all the aspects of care in terms of a healthy approach to living. So balancing work stress, exercise, your medical care, attending for medical visits, and having family supports, your faith, and good nutrition, all really part of the equation in being as healthy as possible. And then lastly, this slide is courtesy of Dr. Athali, who did all the work. But really it's to highlight all of the preventative and contributory things that go into stroke prevention apply to just sickle cell care in general. So if, for example, here, avoiding acute chest or lung damage, because acute chest is tied to stroke events when patients come in with acute chest syndrome. Sickling damages your blood vessels and increases your chance of stroke. So being adherent to hydroxyurea therapy being as well as possible from your sickle cell. If you have kidney damage, which can occur as part of your chronic sickle cell disease, that is going to increase your blood pressure, and hypertension has an association with stroke as well. So all of the component things for caring for your disease impact on your overall health and your stroke prevention as well. Excuse me. So to summarize, so stroke is not an uncommon event in sickle cell disease. It can have a significant life impact. Stroke management is multidisciplinary, involves supportive care, and exchange transfusion is an important part. Stroke prevention revolves around optimization of your sickle cell disease management, transfusion, hydroxyurea, surgical revascularization, and as well exploration of curative therapies for those patients who have that option. And I will end there. I'll stop my screen share now.
Thank you so much, Dr. Williams and Dr. Athali. We have about 10 minutes to address some of the questions that are coming up in the chat. Some of the questions I think you've addressed, both of you, through the course of your presentation. Thank you again for that excellent session. There is one question about general terminology that I think would be good to be very clear on. Dr. Athali, there's a question about what is an infarction? What does that word mean when we're talking about stroke?
So infarction is almost similar to ischemia. So we call it as an infarct. It's mutually exclusive or used term for alternative. So if you have a blockage, you can say that, okay, that patient had an infarct. So an ischemia kind of says that there was no oxygen supply or blood supply, whereas infarct meaning there was no blood supply and there was a brain damage secondary to that. So you can have ischemia or infarction. So like you could have heard about myocardial infarction, right? So when you have a transient ischemic attack, you have limited blood supply or a short period of not having blood supply. But when you have an infarction, there was prolonged period which kind of caused death of the tissue there. Does that make sense?
So I hope that that's addressed the question of the audience member. If not, please go ahead and write again in the Q&A, and we'll keep an eye out. There were a few questions in the chat about adults and silent cerebral infarcts. And so for adults, I know that Dr. Athali, you talked about the recommendation for an adult to have at least one MRI to look for these silent infarcts. For adults that do wonder about whether they have experienced cognitive changes, what would you recommend for them to ask of their care providers?
Sorry, I was muted. I think it would be if you are experiencing any cognitive changes, or if your family relatives are kind of pointing it out to you, I would suggest going to the care provider, especially if you have a hematologist, to go there and kind of bring that issue to their knowledge, because then they can at least do an MRI or imaging studies to make sure that the brain vasculature is in the healthy form. And then if you're not on any prophylactic therapy, that might be the kind of way to have discussion with your healthcare provider to see what can be done. Also, as Dr. Williams has mentioned, and I noticed the question in the person who asked the question in the question and answer box is doing all the right things, but making sure that you do have healthy habits, you're kind of preventing other aspects which can affect the brain function. So.
Thank you so much. There was also a related question about adults who have experienced a stroke. Is there a recommendation around doing repeat MRIs in the future for someone who has had a stroke previously?
Susan, you want to answer that, or you would like?
Yeah, sure. Yeah. So once you've had a stroke event, so you've had a clear stroke, definitely there are sort of the standard practice would be to continue to survey for development of new lesions, and in particular changes in the vasculature, because as we've talked about, that's a really very strong predictor of which patients will be at higher risk for further neurological events. So that may be as frequently as every 6 months. More typically, it would be every 1 to 2 years if a patient is relatively stable on their ongoing preventative therapy.
Thank you. And there's a clarifying question about hydroxyurea and stroke prevention. The participant has written, just to clarify, there is great success and less cases when hydroxyurea is used for patients with no blood transfusion in the treatment of stroke. Dr. Williams, I wonder if you can clarify based on that comment.
Maybe I could just ask for which comment was it?
It's the second last comment there that you can see in the Q&A.
Okay. On the bottom. Okay. I'm looking in the reverse sequence. Okay. So the question is there great success in less cases when it is used for patients with no stroke, with no blood transfusion in the treatment of stroke? So hydroxyurea would be considered a second line option rather than the first line option for treatment of stroke. So the standard of care in a center or country where you can offer transfusions would be to transfuse. If you cannot transfuse for whatever reason, that may be religious reasons for the patient that transfusion is not an option for them. It may be because you can't find blood that matches because they've developed reactions to blood in the past. And so transfusion is off the table. Then hydroxyurea becomes a reasonable option because it's better than just letting the natural course take effect. It does have protective effect, but it would not be considered the ideal therapy. If you could transfuse, you would transfuse instead. I hope that answers the question.
Great. So I think that clarifies things. Thank you. There were a few questions, additional questions about hydroxyurea. So asking about at what age hydroxyurea can be started and what are some of the adverse effects that can go along with hydroxyurea.
So I think I can take that. And hydroxyurea can be started as early as even 9 months to a year. So the current recommendations are that you start low dose hydroxyurea, even if the child is not having any problems. And the reasoning for that is that the fetal hemoglobin, so when a baby is born, about 85 to 90% of the hemoglobin is the fetal hemoglobin, because that's the hemoglobin that the baby has in utero. And it takes about 12 months to a year, 12 to 15, 16 months for the hemoglobin F to completely disappear. And that is the reason that you don't see much of a problem in the form of pain crisis and other things during the first kind of 8 or 9 months of life. So the current recommendation is that based on a lot of studies done on hydroxyurea, if you start as early as a year, then you could prevent the damage happening because of sickling, because the small damage happens over a long period of time. And I would have loved to show the slide about how the recent advances has almost laid the life expectancy to near normal in patients with sickle cell disease. And this is because there is ongoing damage which happens even if the patient is not having a pain crisis or sickling crisis or any major damages. anytime there is a little bit of low oxygen level or the blood is flowing through a minute cavities of the bodies, there will be sickling and there will be a small damage. And that can be prevented by starting hydroxyurea. Hydroxyurea is safely tolerated. The major side effect is a suppression of the bone marrow. So sometimes it can cause low counts, but we monitor the counts very well. And as you may recall, I have shown in one of my slides that sometimes having low white cell counts is important, because it's been shown that patients who have high white cell count, high platelet count, and high hemoglobin level tends to have much higher sickle cell related complications, namely pain crisis and other things. So those having low counts is in fact better. It also, sometimes the side effects could be some hair loss, but I must say that I have so many patients on hydroxyurea and I haven't seen the doses that we use are much less than what we use for patients with cancer. So that is much less. So we don't see those side effects. Some patients may experience nausea, vomiting, or some GI disturbances, and hyperpigmentation. Those are the common side effects. But overall, it's very well tolerated. And just remembering one thing, hydroxyurea can only help if the patient takes it. So, thank you.
Thank you. One last question. We've got so many fantastic questions in the Q&A, and hopefully everybody has seen a note posted in the chat from Aika, who is helping on the tech side of things today. So Aika reminding us that if we don't get to all the questions, which we won't today, that you can please go ahead and send those to communications@sicklecellanemia.ca. And Skago will forward those questions on so that we can still get them addressed. One final question was about timing for getting care for someone experiencing stroke symptoms. And I know this was mentioned by each of you, but I think that that's a very good reminder and a way to wrap up this session. So if someone is concerned about themselves or a loved one experiencing stroke symptoms, what should they do?
I think I hope Dr. Thali would agree, but if you're concerned that someone is having a stroke, you should call 911. So if the patient or the individual family member, child, whatever, is having symptoms or signs that is leading you to believe that there could be a stroke event happening, you need to be in an emergency room. So that's calling 911 and getting there as soon as possible. It is far better to get there and be told you didn't need to come, this is not a stroke, rather than waiting to try and figure out if it is a stroke or not. So immediately proceed for medical attention.
Right, and I think I cannot emphasize that there are no home remedies or other things which can help take away the stroke. And even when, as we mentioned, that if there is a transient attack, even if there was like the symptoms disappear, that requires to be seen by a physician because a second attack might be severe. And for patients, for adult patients, if they have stroke, to reduce other damage, there could be some immediate things that the physicians can do either in the emergency room or otherwise. So yes, I totally agree.
All right. Thank you both. I think that that's a great way to wrap up our session. So I hope that that was a very useful talk for everyone listening. We were very fortunate today to be able to benefit from the expertise of Dr. Williams and Dr. Athali. Thank you both so much for joining us for this session today. Again, please do submit any questions that you didn't get answered today to Skago so that they can be forwarded on to Dr. Williams and Dr. Athali. Thank you to everybody for participating. Thank you for submitting your questions. Thank you for your active engagement through the session. Thank you to Aika for helping with the technology side of things in the background. Thank you to Mrs. Lanre Tunji-Ajayi for organizing this session and being the leader of SCAGO. Please do keep an eye out for the SCAGO newsletters. There are a number of other very exciting events that are coming up in the next little while. On June the 11th, there will be a session on pain management. And on June 14th, it's World Blood Donation Day. And of course, June 19th is World Sickle Cell Day, and there will be upcoming events around that time. So please do stay tuned and check out the SCAGO website. All right. Thank you, everyone. Have a healthy and safe rest of your weekend.
Thank you.